Oh, there it is. Like looking for my phone, I put it down.
Same thing.
We have a few minutes here where we have everybody,
Okay.
and also I know Rowan was supposed to introduce you. Sometimes our room changes, so I just. Twenty-one people online. So you know. I don't know. Secret. If, but so moving around sometimes is. That's all. Pseudo people. Step. Yeah. She's a CSDE system.
Right now.
She's not sure actually right now. But she's working on working on this, our scientific director. At some point, yeah, at some point, I would love, we need to start thinking about. This get us started. I get us started, Jess. Is that okay? Welcome everyone. Midwinter quarter. There's always a moment in which we're a little bit worn out this time of the quarter, but at least this rain stopped today, and I'm really happy to welcome all of you for our Friday afternoon seminar. It's nice to see several new faces as well as our returning folks, and welcome to everybody online. My name is Sarah Curran. I'm the director of the Center for Studies in Demography and Ecology, and I'm delighted to welcome one of our newest affiliates, Kemi Dahl. Kemi is a MD and professor of obstetrics and gynecology, a field that I not familiar with, but my sister is an OBGYN, so I get to hear some of the ins and outs and various aspects of her world. Dr. Dahl is the project lead of the Endometrial Cancer Action Network for African Americans, ICANA, and will be talking to us about how to approach the investigation and intervention of endometrial cancer inequity. I wanted to mention that as another hat that I wear is Associate Vice Provost for Research at the University of Washington. And we have just put forward a task force that I helped lead, put together a proposed framework for how to do comprehensively approach equity in our research agenda at the University of Washington. So I'm super excited to have Dr. Dahl here to present. I'm hoping to learn also in terms of how we think big picture from start to finish, how we think about our research with an equity mindset. And thank you. So welcome so much.
Thank you, Sarah, for the welcome. Thanks all of you for coming in person, and thank you to everybody on Zoom as well. Let's get started. Okay, there we go. So I'm going to describe some theories and frameworks that underpin race, gender, and health and society as they have been useful to my research program. In doing so, I hope to elicit some understanding about novel findings on the causes of the Black-white mortality gap in endometrial cancer that affects us today. And then to spend a good amount of time reviewing several studies that we have in progress trying to tackle this issue. Okay, so endometrial cancer is a cancer that lines the womb. So it is distinct from cervical cancer, fallopian tube, or ovarian cancer. It's called endometrial cancer because the tissue that lines the inner lining of the uterus is called the endometrium. And there's about 65, almost 66,000 cases, new cases in the United States per year now, which translates to about a lifetime risk of 3% for individuals born with a uterus, or 1 in 32 by age 80. Endometrial cancer, up until very recently, had a very good reputation, I would say, as a cancer that has an over 80% 5-year survival. As a gynecologic oncologist, when I was training, you know, what we were told is like, ovarian cancer is super deadly, everybody is gonna die, cervical cancer is bad, rare, but preventable, and endometrial cancer is the good cancer because it happens a lot, it's common, but we can mostly cure it with surgery and keep it moving. That was kind of the story of endometrial cancer. However, endometrial cancer has been on the rise now for several years, and it's actually one of the few cancers that's on the rise in the United States. Most cancer incidence is decreasing, but not endometrial cancer. One reason for this is the sharp decline in hysterectomy rates in the United States. This is not in and of itself a bad thing. We probably were doing way more hysterectomies than necessary for a really long time. But the bottom line is, as patient preferences and as guidelines have been developed around the appropriate use of hysterectomy, we've seen it was a 40% decline from 2000 to 2014. It's even more so now. And given that hysterectomy was the second most common surgery among folks with a uterus, outside of C-section, you can imagine how impactful that is in creating a denominator of folks who are still at risk for endometrial cancer as they age. So when you actually adjust the endometrial cancer incidence for hysterectomy, in other words, if you just look at the incidence among people at risk, you see endometrial cancer is actually even more common than we think. So it's more like 88 cases per 100,000 folks who still have a uterus, which puts it on par with some of the other common cancers we think about, like breast, lung, and colon cancer. All right, the other fact that I want you to walk away with for endometrial cancer is a little bit of a personal soapbox of mine, so I apologize in advance. I'll come to it a couple times, but I want you to be my foot soldiers for coming against this narrative. One of the things, if you Google endometrial cancer, if you look at any news article about endometrial cancer, they inevitably will talk about the obesity epidemic and how endometrial cancer is increasing because the obesity epidemic is running rampant and it's an obesity-driven disease, et cetera, et cetera. What's really interesting about that is that there are two types of endometrial cancer, type 1 and type 2. If you would imagine, one of them is hormonally driven and very much driven by excess estrogen, which is a secondary consequence of bigger body size or obesity. So you might look at this graph that I'm showing in terms of the changing trend of endometrial cancer and assume that the type 2 cancer is the obesity-driven, estrogen-dependent cancer, but it's not. Type 1 is the obesity-driven, estrogen-dependent cancer. Endometrial cancer is on the rise because we are seeing more non-hormonally driven, non-estrogen-dependent endometrial cancer increasing, and we don't know why. And so the conclusion from this paper, this is from 2019, this is actually sponsored by the NCI, is that the observed increases in non-endometrioid, that's the type of endometrial cancer, combined with more stable rates of the hormonal type, really challenge the prevailing hypothesis that the obesity epidemic and changing prevalence of hormonal risk factors are major contributors. So one, I want to point this out because I think it's just another example of how the obesity conversation can really cloud scientific innovation and development. And two, just to introduce you to what is currently like a very interesting mystery in cancer and incidence right now, which is why is type 2 endometrial cancer increasing? And right now, we don't have the answer to that. And I got you really excited about that, but I'm not gonna talk about that much more. So overall though, regardless, this is it possible to get the okay? Oh, okay, I see.
I didn't know that was gonna come up for you, sorry.
Okay.
I thought it was so slick.
No, it's okay. Is
I'm
this?
interrupting you about it.
Do I hit okay
Yeah.
here?
Yeah.
Okay, I'm good with it. Hey, no, we all have a better experience. Okay, so race and ethnicity. So these are US uterine cancer statistics. To be very specific, endometrial cancer is a type of uterine cancer. There are other very, very rare, much less common types of uterine cancer, but endometrial cancer is like over 95% of uterine cancer. So we tend to use the terms interchangeably. But you can see here, overall, the burden of endometrial cancer between Black and white individuals in the US is generally around the same. So it's not exactly the same, it's generally around the same. But the problem is the mortality is not. So this is a mortality graph. So Black people in the United States who get diagnosed with endometrial cancer have a 98% higher mortality than white folks do after 5 years of diagnosis. So this has been the case for decades. If you go back to 1974, this graph looks exactly the same, which is when we started collecting SEER statistics. And as you go forward, it not only looks the same, but it actually just gets worse and worse and worse. In addition, I told you the kind of old adage about ovarian cancer mortality and that being our most lethal gynecologic cancer. But for Black women, uterine cancer mortality has been greater than ovarian cancer mortality since 2005. So I'd like to put this disparity into context because I find that when we talk about disparities, especially if you're not familiar with the topic, you might not know, like, how does this compare to all the disparities we tend to hear about a lot in cancer care, and how it compares is poorly. Endometrial cancer or uterine cancer actually has one of the highest magnitude of disparity across all cancer types. So breast cancer, cervix, colorectal, these other cancer types we hear about that have disparities, the magnitude of difference between Black and white individuals in uterine cancer is higher, and again, climbing. All right, so I've told you about the problem, which is the Black-white mortality gap in endometrial cancer. And now I'm gonna spend a little bit of time talking about my theoretical grounding and some early work that laid the foundation for what he. So one of my grounding perspectives on this problem is actually not to think about it from the lens of cancer, but to think about it from the lens of reproductive health. Black women from the time of the reproductive years experience gynecologic care that includes higher rates of having fibroids, irregular cycles, less success with infertility, more premenopausal hysterectomy, on to the actual active reproduction, where Black women have higher rates of preterm labor, low birth weight infants, and maternal mortality. This is something that people are very aware of right now. But I like to remind us that it fits within a spectrum of reproductive care. On to the postmenopausal period, where Black women have higher mortality in all of the gynecologic cancers. So we can look at this life course perspective of reproductive health, and we could say, what is wrong with the wombs in Black individuals' bodies and Black women's bodies? What is wrong with them? Or we can look at this and we can say, what is wrong with the environment and the care and the science and the research and the treatment of how we manage Black women's gynecologic health over the course of their life? So I choose the latter perspective. I think it's more interesting. And also because I do have a perspective on this, and this is like my disclosure slide. I feel like anybody who does any equity research, but especially racial equity research, should be really clear about what perspective they're bringing. And my perspective is very much informed by Black feminist thought, by medical sociology writing, and really about people who are trying to grapple with how do race, gender, and health intersect in the specific context of the United States. And from this background is where the three frameworks that I tend to use come from, and I will review them very, very briefly and acknowledge that each one could be its own hour-long talk. But for the purpose of introduction, the public health critical race praxis is a adaptation of critical race theory, which was originated in legal studies, has been translated to the education world and now the public health world. It has several principles and foci. But one of the most important is that racism is omnipresent in society and it's active in the daily lives of people of color. So there aren't places in society where like racism does not exist. You know, there are not there aren't environments we can somehow find where somehow racism isn't there anymore. And that'll come up in a little bit. But it means that racial biases inform the nature of our research questions because we're swimming in this racist soup. It also drives our a priori assumptions about research. Okay, this thing just gave me some weird, cross this off your list. I'm just gonna say, remind me tomorrow.
Yeah, that works.
Okay, we're good. Okay, sorry about that, y'all. So given that racial biases inform the nature of our research questions and our assumptions, it made me curious about how has even the knowledge about Black women with endometrial cancer been constructed? Like what has influenced how we even think about this problem? The second theory is the fundamental cause theory. which is very well known and really explicates the link between socioeconomic status and mortality that persists over time due to differential access to these key flexible resources. We all kind of understand this intuitively that, you know, almost in any given society, in any given setting, you take the folks who have the lowest socioeconomic status, and they're pretty much always doing the worst. But it also means that the differences in health outcomes that are based on social position, like race in the United States, they arise in the context of the treatability of a given condition, how much it is amenable to intervention or amenable to prevention. If you can't do anything about something, you don't see large disparities. It's when the society can make a difference that you start to see disparities. And so that really led me to the question of what are the modifiable factors that contribute to that Black-white mortality gap that you saw there. And then finally, the eco-social theory of disease distribution, I think coalesces around a central idea, which is how we as humans literally biologically embody our exposures that arise from these different societal and ecological contexts, and that can also produce differential population rates of disease. And that really led me to be curious about how the social environment influences biological differences in endometrial cancer histology and outcomes. So starting with the public health critical race praxis, we had to start with reviewing the literature. And so, like anybody will tell you, you want to enter into a field and start studying it, you have to go back and see like what has everybody said, what has already been found. And so we did that kind of review, but we also applied a race conscious lens to ask like, how are Black people being conceptualized in this research? What are the underlying assumptions that are in these papers? And so in reviewing the discussion sections and like really looking at what things were coming up, we found two things. One, that race was defined pretty much exclusively as a biological or genetic entity. There was really no, at this point, this was in 2017, there was really no concept or kind of discussion in the literature as race as a social construct in any way. This was really important because it also led to this assumption that healthcare environments represent colorblind spaces. So what I mean by that is that if there was a study that came out of a single institution, or for example, a study on a clinical trial, and Black women on the trial or in the institution didn't do as well as white women, the assumption was, well, there's no difference in their care, there's no difference in their experience, so it has to be a biologically driven problem, right? So this idea that there are these like colorblind spaces in healthcare. You know, what this led to was really repeated, almost like clockwork every 10 years. Observational studies documenting, for example, Black women were not getting surgery to the same extent as their counterparts every 10 years with no work to actually address the inequity. And so this isn't about like work to solve the problem, but even work to take the next step, like why might this be happening? Let's figure out the causes, which would make sense if race is just a biological entity, if there's no social components to evaluate. And then finally, because of this assumption of color blindness and no difference in experience, we really had the absence of the Black woman's voice in endometrial cancer research. You didn't have any qualitative work, you didn't have any survey work, you didn't have anything from the Black woman's perspective about their own diagnosis and experience. So, you know, these were the mortality statistics, or are the mortality statistics at the time that we did this review. And, you know, what we found in 2016 was we had about 30 years of theoretical research, we had no qualitative work, we had no intervention work, and we had no public health awareness. So this is why I'm such a firm advocate that research on racial disparities in health should be theoretically grounded and informed by race scholarship, so that we spend our time and our money and our efforts making tangible progress on these problems. Okay, so fundamental cause theory. So differences in outcomes based on social position in society arise in the context of treatability of a given condition. So I love this because you can actually see it play out within gynecologic cancers themselves. So we have cervical cancer that is at this point almost completely preventable, but definitely very treatable when caught early stage in the pap smear, in the screening algorithm. We have ovarian cancer, which I already told you about, that like most people who get ovarian cancer die of ovarian cancer. We've made a lot of progress, but 10-year survival has not budged in decades. And then you have uterine cancer that fits in the middle, and you see how the Black-white mortality ratio is different by their relative amenability. And you also see what's happened with cervical cancer when we've had resource-independent, public health-driven efforts you see a decrease in that disparity. We haven't had the same for uterine cancer. So what are these modifiable factors that we can change in endometrial cancer? So we started by doing a cohort simulation where we used SEER-18, which is a national cancer registry in the United States. We looked at endometrial cancer cases over 5 years, which ended up being about 34,580 cases. And we basically just asked the question, like, these are actual cancer cases. These are annotated folks with like annotated information, their histology, their age, their treatment, et cetera. What is the impact if we don't have a racial disparity in who gets surgery and who gets not? What is the impact if we don't have a racial disparity in stage of diagnosis? And we did this for a few different variables. And what we found was that the mortality gap that we could measure was largely driven by stage of diagnosis and surgery rates. And most of that was stage of diagnosis, about 40%. At the time, this was really different from the dominant narrative, which was that we had like an essentially biological problem with Black women. So that really drove the hypothesis for my career development award, which is that stage of diagnosis is a major and modifiable contributor to racial disparities in endometrial cancer. And the reason why I came back to the review, which is that racial differences in stage of diagnosis vary by healthcare setting. So vary by vertically integrated healthcare systems, non-vertically integrated, et cetera. So unless all of these different Black women have somehow different genetic makeups across all of these different studies, we have to acknowledge that there's something going on with the environment. In addition, guidelines for the diagnostic workup and management of endometrial cancer symptoms allow for many pathways to diagnosis, and we're gonna like really live in here for a few for this section of this presentation. So endometrial cancer is diagnosed because somebody has one of the cardinal symptoms, which is called postmenopausal bleeding. Median age of diagnosis is about 63. So the vast majority of people have gone through menopause. They have bleeding again, and then they seek evaluation either, and you can do either an ultrasound or an endometrial biopsy or a DNC to evaluate that bleeding, and they get diagnosed with endometrial cancer. Okay, what's interesting about this from a health services standpoint is that each one of these procedures require different kinds of training and different kinds of resources available. So an ultrasound can be ordered by any kind of doctor and can be done in most centers. Endometrial biopsy takes a certain amount of training. Some OBGYNs and family medicine doctors have it, some don't. Some family medicine doctors have it, and then a DNC is usually the purview of OBGYNs only. So that allows a lot of different variation of care right there. But in addition to that, adherence to these guidelines might be influenced by the normalization of bleeding in Black women by patients and providers. And this is where that context of Black women's reproductive health is really important. Because if we take an entire group of women that have higher rates of fibroids that cause irregular and heavy bleeding during their reproductive years and irregular cycles to the point that abnormal bleeding and irregular bleeding become a normal experience during the reproductive years, it can create an abnormal normalization of bleeding in older women. That might not prompt the same evaluation and concern, not just by the women themselves, but also by healthcare providers. And so I think the way to think about this is that we may have a racialized view of the primary symptom of endometrial cancer where two people can come in with the same complaint, but the interpretation and the worry is different because of antecedent racial patterns. Okay. So this became basically the organizing framework for my career development award. And I found this wonderful model called the Anderson model of total patient delay and applied it to endometrial cancer. And so you can see the kind of specification at the top there about like the different influencing factors within each phase and the events from detection of bleeding to the start of treatment. Now, I think what's really interesting about this model is that it defines these intervals more specifically than the idea of like, when did this start and when did you get diagnosed? There's the appraisal interval, the help seeking, and the diagnostic interval. And what's more important is that there are different influences in each one. So if you're not careful about what interval you're studying and what you're looking for, you're going to collapse things that don't need to be collapsed. We might miss factors that are actually really important. Okay, so let's talk about vulnerability to care delay in endometrial cancer. So I started with the diagnostic interval because it's the easiest to study because it starts with the first consultation with a provider and ends with the histologic diagnosis. So it's all captured in the medical record, right? It's all like somehow you can find it essentially. And so our thought was, what's going on with this pattern, especially given the potential variation that we saw before? So one of the first studies we did was a SEER Medicare study. And so this is the SEER Cancer Registry linked to Medicare claims. And so what this means is that everybody in the study is insured. And not only that, we limited the population to people with a year of continuous insurance before their initial symptom presentation, and people who clearly demonstrated ongoing care. So like they had a PCP appointment, they had some kind of interaction in terms of their Medicare claims. So we looked at 10 years of endometrial cancer cases, and we identified symptoms, mainly bleeding, and then procedures prior to diagnosis. And what we found was that Black women had an increased risk, and that's a relative risk, that's not an odds ratio, of non-guideline adherent workup. So these are women who are insured, going and seeking care, and have coverage, who are not getting appropriate diagnostic procedures. And so these non-guideline pathways were associated with increased stage 3 and 4 disease. And so you'd have a woman who saw her cardiologist, she saw her endocrinologist, she saw her podiatrist, and she's going to the doctor, and then she finally gets this visit and she has stage 4 uterine cancer. It's like, how is this happening? So this was our first clue that it's not just an access to care issue. So what we concluded is that Black women, I forgot to tell you all this. So Black women are at greatest risk for that type 2 type of cancer that's more aggressive and that's non-hormonal. So even though we already know that they're more at risk for that type of cancer, they were less likely to have their bleeding categorized as postmenopausal. So these were all women enrolled in Medicare. So everybody was over 65, and most of our group was 67 and up. And they were coming in with bleeding, and it was being reported as heavy periods. They were less likely to have their bleeding documented at all, and they were less likely to have appropriate diagnostic procedures. So this became a signal that there's something going on with the quality of care. Now, interestingly enough, I was so ready for like the smoking gun. I was like, all right, we're going to look at the time, and we're going to see that it's related to stage, and we're going to be done and done and done. That's never that easy. So Black women absolutely had a longer diagnostic interval time compared to white women, about 27%. That time, I would not use this word became insignificant if I wrote this again, but essentially it was explained by the classification of bleeding. So the bleeding was classified as abnormal instead of postmenopausal. That prolonged the time to an endometrial cancer evaluation. And then also if they received a procedure, within a week of their symptom presentation to move towards a diagnosis, that also changed the time. And those two variables are why Black women ended up with a longer time to diagnosis. Now, the time individually was not related to stage of diagnosis, because overall, this window, this diagnostic interval was relatively narrow, right? So it was like 28 days between 1 and 110. And this is what takes me back to the care model. Because of course, we can't actually start the journey of disease from the time somebody shows up at their healthcare provider. It's part of why we think about beyond the diagnostic interval. But I have one more thing to tell you about this interval, which is, okay, we found this in the claims. If anybody's done claims research, it's like, it's a mess in there. It's a bunch of ones and zeros. And ultimately claims are billing. It's like, it's billing procedures. So it's not data that was created for the purpose of research. There are some issues there. But we were seeing that somehow these women weren't getting their diagnostic procedures, so we needed to talk to providers. And so part of this grant also planned a provider survey where we wanted to figure out, not just among OBGYNs, but all different kinds of providers, how they interpret and respond to signs of endometrial cancer. So we targeted a broad range of specialty and training. You see that there. Our sampling source was the American Medical Association roster, as well as the Nurse Practitioner and Women's Health Organization roster. And then we did a pilot mailing in December of 2019. We adjusted our sampling to target non-OBGYNs and US Southeast representation. I only point this out because we basically purposely oversampled those two areas that have the lowest response rate. And so we basically compromised the overall response rate for this survey in order to increase and make sure we had representation from non-OBGYNs and all providers in the US Southeast. And then we did our final mailings in June. Oh, okay, that just went away. Okay, you told me that would happen. Okay, our final mailings from between April and June in 2020, which honestly I don't remember. There was also a pandemic, so I don't even know what we were doing. This is what the responses by region look like, so you can kind of see our efforts there of trying to be pretty broad and where we were getting information from. Okay, so we ended up with 531 total response rate, so 32%. I think what I want to point out about these responses is that, you know, we did get a decent number of nurse practitioners, so not just physicians. We did get almost half non-OBGYNs, which is exactly what we were trying to go for. A lot of 67-year-old women don't have an OBGYN anymore. They're not going regularly, right? They're going to, again, a cardiologist, they're going to other doctors, their emergency medicine, internal medicine. And then we also were successful in getting you know, almost half of representation from the South, since that is the, by far the area that's most concentrated with Black people in the United States. So what did we find? Okay, so 64-year-old with postmenopausal bleeding. We offered several guideline choices, a transvaginal ultrasound, an endometrial biopsy, or anything non-guideline adherence. We had several choices, and about 10% of the providers did not choose the correct next step. And so case one is like this is like the slam dunk. This is like, there's nothing else to do with a 64-year-old with postmenopausal bleeding except get an ultrasound or a biopsy. So that wasn't great to see. And then we intentionally made it more gray zone. So case two, we have a 55-year-old with symptoms of menopause, erratic bleeding. She has an ultrasound, she has fibroids, but I'll tell you this 8-millimeter endometrium thickness, that is the ding, 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 because anytime the endometrium is greater than 5 millimeters, that's a concern for endometrial cancer. 40% of people are not choosing a guideline adherent pathway. And then we did a younger woman with a BMI that would be in the obesity range, because we were curious, well, would this prompt people to think about endometrial cancer because of the dominant narrative? It didn't. 34.5% still did not choose an endometrial biopsy or DNC. Okay. So I knew, like, I actually didn't know what the numbers would be here. So we included a control case, because I'm like, what should we expect? I have no idea. And our control case was a woman, an older postmenopausal woman with a breast mass. Everybody knows what to do, right? Like, you got to get an ultrasound, you got to get a biopsy, somebody has a breast mass, you got to figure it out. 2.2% shows. So we have a problem here among providers in terms of knowing about endometrial cancer and knowing the appropriate next steps. So in this diverse sample, essentially first-line providers, they demonstrated only moderate EC knowledge. They had a lot of non-guideline adherent management choices, and in the choices, they also clearly preferred transvaginal ultrasound over biopsy. And so that kind of prompted the next part of our work. Okay, so I just spent a lot of time talking about diagnostic interval. There's clearly delays there, but also, as I said, there are delays there, but independently, that's not driving differences at stage. So we gotta get earlier in the process. And so we have to move to the appraisal interval. Now, the appraisal interval goes from detecting a symptom, so I detect that I am bleeding, to I perceive a reason to seek care. That is an internal experience. That is not in claims, right? You can't find that anywhere, so you have to talk to people. So this is qualitative work. So we set out to do this national qualitative interview project to understand how Black women are experiencing symptoms and then their healthcare interactions prior to and then during their diagnosis of endometrial cancer, because we wanted to understand what was going on in this interval. This was a community-engaged qualitative study. We ended up speaking with 32 Black and white women with endometrial cancer, with 1 to 2 hour, pretty long interviews, all about what was going on during the time of their diagnosis and before. And what was very unfortunate but very consistent was Black women expressing multiple factors that we already know are associated with delay from the Anderson model and other studies. So the nature of their symptoms they were reporting as not new, bothersome, or painful. This is just like the bleeding I had in my 20s. Like, why am I worried about this at all? Misattribution of their symptoms to fibroids or irregular cycles. We did not have fibroids or cycles in the interview guide. So then we were just asking, like, tell us about what happened when you started bleeding at 60 something and they were bringing these kinds of things up consistently. Importantly, their cue to action was not, I have postmenopausal bleeding, I need to run and get this checked out. It was, oh, this is weird. Let me see if it goes away in a month. Or let me see what happens next. It was some personal waiting period. I will go when my PCP appointment is. It's January, I'll go in June when my PCP appointment is. Or increasing symptom severity. Well, now the bleeding is worse. Well, now it's cramping. These are signs of cancer progression, right? And then finally, sadly, symptom disclosure, when they would when they would disclose symptoms, their response would be very misaligned with their risk. So a lot of, oh, well, maybe that's just your fibroids, or let's just check that out next time. Or even, maybe we should get an ultrasound to check that out. So that probably sounds comforting, maybe, but I don't know about you all. But if I brought a symptom to somebody and they thought that symptom might mean I have cancer, I would like to understand the importance of going to get an ultrasound and why that would matter. So what women were telling us were like, well, they said to get an ultrasound, but it's like, I've had like 5, 6 older, I'm not even bleeding anymore. It's not like I'm sexually active. Like, what am I getting an ultrasound for? They really did not have a sense of why that was being recommended. So lots of fodder here for prolonged delays. And it's really hard to present a qualitative study in one slide, but I just thought this was the best quote to pull out, which is, I was just surprised, not alarmed, because it wasn't heavy at all. So she's talking about her bleeding was not heavy, which it usually isn't. It's a couple drops of blood, it's not heavy bleeding. It was very light. She was like, is that blood? Because it was nothing compared to what I've been used to since I was in my 20s, nothing. So this woman waited a year. She was like, this is like not a big deal. Okay. So what's interesting about this is that I don't know that I had to even do those studies I just told you about. Differences between Black and white patients with cancer of the uterine corpus in interval from symptom recognition to initial medical consultation. So first of all, this does combine 2 intervals, but we'll let it go. Appraisal all the way to the beginning of diagnostic. They did a time to event analysis. They looked at the rate of initial medical consultation per person days following symptom recognition. These were epi people, obviously. So overall, what they found is essentially all you need to know is the higher the number, the faster it happened. And they clearly found almost it's a 50%, Black people were half as quick as white individuals to move from symptom recognition to medical consultation. But then of course we adjust. We adjust for things like geography, even though we deal with residential segregation in the United States. We adjust for things like blue collar job. We adjust for things like whether you have a PCP. We adjust for all of these things. And so the adjusted relative rate ends up at 0.83. It crosses 1. And the conclusion of this paper is that there is no difference. So in addition, in the discussion, they note that bleeding was the primary symptom, right? So they were also trying to figure out, well, what is the first symptom that people experience? Well, bleeding across race, bleeding was the primary symptom. So there was little racial difference in the fact that that was a primary symptom, but thus it is unclear how there may be cultural differences in recognition of this symptom. Okay, so our racial positioning, our awareness, or our lack thereof influences the design and interpretation of our studies. This is why engaging with the marginalized community of interest is required in any true effort aimed at healthcare equity, right? It's not like a bonus, it's not like a nice to have. It's required because otherwise we will miss things that are right in front of us. So what we started to put together is this idea of overlapping vulnerability, which is that we started to, with the qualitative interviews and some of the other quantitative work that we've done, we started to notice these gaps in information that was leading people to have longer and longer appraisal intervals before they even got to care. And that was knowledge about menopause, experience of prior negative reproductive healthcare events, as well as other concurrent conditions. And then when you add it to that, structurally, the access to care issues that we know Black individuals face in the United States, and from an epi standpoint, the underlying elevated risk of the aggressive histologic subtypes, you start seeing how the vulnerability starts overlapping with Black women to a great degree. And it doesn't mean that these factors aren't present in white women at all, right? It's just about the relative nature of what we see. And so I really like this because it's a way that we can start thinking about vulnerability across a lot of different populations, not just Black individuals. There's now there's research coming out, especially about Pacific Islanders and endometrial cancer, very overlooked group, very poorly researched group, where we're finding some of the similar things. So I have to say that when I first started doing this research, I thought, okay, this is the best model ever. It's also very lovely colored. And I'm just gonna spend 30 years working this model and making this times quicker and quicker and quicker, and I'm gonna solve this problem. But it turns out that it's always more complicated than you think. Because the other thing I was hearing was, I did go to my ultrasound. I did do that, and they told me everything okay, that it was just my fibroids. I mean, I went to get the test. And I thought, wait, we haven't asked another question. There's another question we haven't asked. So this guidelines, this, you can do an ultrasound, you can do this. How do those guidelines for transvaginal ultrasound screening in particular, the things that providers are most likely to go for, how do they perform among US Black women at risk for endometrial cancer? I only asked this question because I was trying to write a grant and I wanted to use this as a background sentence and I could not find it. And I was like, oh, we don't know this estimate. So let's just go like do it really quick. So here's some background. 90% of women with endometrial cancer present with postmenopausal bleeding. So I told y'all that's definitely the cardinal presentation. However, only 10% of women with postmenopausal bleeding have endometrial cancer. Okay, so it's not really cancer screening, but it has that similar idea, right? Where you have a lot of people, only a few of them have cancer, but you want to try to find them. Transvaginal ultrasound is recommended to screen women and avoid unnecessary endometrial biopsy for all of those other women who don't have endometrial cancer. And the way that we do that is by endometrial thickness. So if the endometrial thickness is less than 4 millimeters, then the biopsy can be omitted with a 95% sensitivity and a 99 to 100% negative predictive value. So I want you to remember that, 99 to 100%. That was based on 4 population studies in Scandinavia and Italy and Hong Kong. So here's some other background. Black women have higher incidence of fibroids and larger fibroids that persist later in life. Those 4 population-based studies didn't include Black women. They also didn't include women with fibroids. Black women have 2 to 2.5 higher risk incidence for that non-endometrioid type 2 histology. And it turns out that histology type does not necessarily reliably create that global endometrial hypertrophy that is captured using this thickness measurement. If you look overall at endometrial cancer, only 10% of white women have a type 2 endometrial cancer. So it seems like a small amount of people. If you look at Black women, 30 to 50% of Black women have a type 2 type of endometrial cancer. All right. So we did a population simulation, again, SEER 18, again, looking at endometrial cancer cases. We used the US Census and we used the Black Women's Health Study and the National Institute of Environmental Health Sciences uterine fibroid study for fibroid incidence by age group, by race in this country. And then we used the published literature to look at the distribution of histologic type, fibroid history, and ET visibility, endometrial thickness visibility in the presence of fibroids. And we use these diagnostic performance tests to capture the quality. And what we found was very disturbing. So we ran this a few different ways, but essentially the sensitivity was much lower for Black women than we expected to see. And I really didn't believe this, honestly, but the AUC needs to be greater than 7 for it to be a useful test. So it was 0.57. So we did a bunch of sensitivities. We excluded one study that we had included because it was the only one we could find with Black women, and a study from Jamaica, but it wasn't high quality. We also assumed that we could have a higher quality of ultrasound with fibroid visibility. So we upped that to 70% and then 80%, but we could never get the algorithm to actually be functional and work at the same level that it theoretically is supposed to work for white women, for everybody. So then after that, we were like, okay, well, maybe this is all just a fluke. We actually have to compare. We have to do the same simulation and the same calculation for white women to see if it compares to the published data, right? To see like, is our simulation accurate? And so we did find that the sensitivity of white women was about 87.9%, so lower than that 94%, but not insanely off. And again, that negative predictive value was 97%, so close to what was supposed to be there, but clearly not the same performance by race. Again, due to the fibroids and due to the type 2 histology type. So this was really interesting because we have guidelines that emphasize transvaginal ultrasound, but those guidelines are based on a paradigm. So they're based on a paradigm. One, they have a low risk population. 90% of people, white women, have low risk endometrial cancer, which means that if you miss it, it's low risk and slow growing, and so you have a lot of chance to catch up. It also is based on a paradigm of a high accuracy of the test, and the ultrasound will pick up the thickness, and that will indicate an endometrial cancer risk, and again, low consequences in the setting of a false negative. Unfortunately, None of those assumptions apply to Black women in the United States and endometrial cancer. Not low risk population, the test is not accurate, and there are high consequences missing it. So this is an example of how our clinical algorithm itself has built in racial inequity. And so even if we do everything to optimize healthcare access and provider behavior and all of that, we're still ending up with an inequity in diagnostic timing. So following this work, we wanted to be able to study this among a live, living, breathing healthcare system. And so I worked with two really incredibly collaborators in North Carolina. And my collaborator, Dr. Robinson, and I, from our early training days, worked on and built this data set called the Carolina Hysterectomy Cohort. And we essentially went back to that and kind of re-abstracted that cohort for this information. And so it was 3,500 Black individuals in North Carolina who all underwent hysterectomy across 10 hospital systems. And we really wanted to see how did this threshold work in real time. I'm going to skip this part for the purpose of time. We did a lot of quality control in the abstraction. That's all you need to know from this slide. It was very painful year-and-a-half process. And we thought about all of the different influences that go into endometrial thickness measurement. So, not just the mechanical influences, but thinking about pre-test biases, thinking about the data quality. This was all in designing everything we were going to capture, but the actual calculation was not difficult. It's like, what was the threshold of the endometrial thickness? Did they have endometrial cancer or no on their final hysterectomy when they finally got one? And so I'll skip this for the purpose of time. So this was what we found in the overall performance of endometrial thickness screening thresholds among 1,494 all Black individuals, some of whom had endometrial cancer and some of whom didn't. So you can see there, if you use a lower threshold, the 3 millimeter threshold, that the probability, what we call misclassification probability, was the percent of endometrial cancer cases that were below the threshold. So you have 3.8%. If you use a 3 millimeter threshold, 9.5% if you use a 4 millimeter threshold, and 11.4% if you use 5 millimeter threshold among actual people who went through the healthcare system and got these tests. I don't know how this lands with you all, but I will tell you that this ultrasound test is designed to just tell you whether you should continue with a cancer workup or not. It's not a test that gives people chemotherapy. It's not a test that puts you on a highway to major surgery. It just says, should you keep looking and rule out cancer or not? So for me, it's completely unacceptable that we would have 11.4% of individuals being falsely reassured, because you have to think about how long it takes you to come back for care if you've been reassured that everything is fine. The second thing is I said, well, let's look at the risk factors for endometrial cancer in particular. So maybe this performs better when you pull out just women over 50, when you pull out people with postmenopausal bleeding, when you pull out, or reported and documented, when you pull out folks that are obese, BMI over 40, it doesn't work any better. It's also not working better for the most common risk factors that we have. So this was a retrospective cohort study of 1,494 Black patients, and 11.4% had an ET below the diagnostic triage threshold for detection. Our conclusion about this is that this is not a reliable strategy among Black adults at risk of endometrial cancer, and we should be pushing tissue biopsy to avoid misdiagnosis of endometrial cancer. This paper is under review right now. So this is not right. So it is no longer the case. I don't think it looks like this anymore. I think this is overly simplified. I think it looks more like this. So we think that somebody starts bleeding, they appraise their symptom as abnormal, they decide to seek care, they disclose to the healthcare provider, that person initiates a diagnostic evaluation and they get diagnosed, and it's a smooth circle. But what we've actually found is that every single step along the way are times where you can fall off of this diagnostic pathway. Black women are much more likely to fall off on this diagnostic pathway, including and up to an actual failure of the diagnostic algorithm itself. And you might imagine that after an exit, you might re-enter several steps back. So after you've been told, oh, it's just your fibroids, how much longer do you have to bleed before you go, okay, well, maybe it is something else. So this is a lot harder to capture in any given EHR claims, but it does start to explain why you're seeing such a persistent pattern of advanced stage of diagnosis of Black women, regardless of setting. So there's no one magic solution. there's actually many needed solutions. And so we're working on them. So at the system society level, we're trying to increase guideline adherent work for Black women. So we do want some action when Black women are reporting postmenopausal bleeding. I'm actually so excited to update the slide to say that the current guidelines to the ultrasound threshold for biopsy are being reworked, and I'm on the writing committee for our guideline update, which is in progress right now. We want to develop provider-facing education on perimenopausal symptoms. So again, especially our non-OBGYN providers know to ask about this and to refer as needed. And then we already do a lot of patient and community work around correcting the myths and silencing around bleeding symptoms, so that there is more clarity about when to go for help. This is one example of our, okay, I need to stop talking. One example of our ongoing studies where we're going to be disseminating what's called a biopsy first early detection of endometrial cancer toolkit called Guides by Us. I'm really excited about this, not just because we're going to do the focus groups and we're going to create this toolkit, but we're also going to be incorporating Black gender expansive people with a uterus. So we've already done 2 focus groups. And we've done 1 focus group, we'll be doing another one, and making sure that our communication tools really apply to all people. And it's really been a major gap area in endometrial cancer research, including my own research up until recently. So I am excited to start to close that gap. So Ecana was born out of a desire to work directly with the community. And I will just throw up this slide for any kind of questions about how you can engage meaningfully with community. Racial concordance is nice, but it's not all that is required. And I wrote this paper because I wanted to see a paper like this, but I refer especially the students, if you want to know what that really looks like on the ground. Ultimately, Ecana, we ended up bringing together Black endometrial cancer survivors for the first time ever in 2019 to Hawaii, and we educated them as peer supporters, as community educators through a community empowerment partners program that we adapted for endometrial cancer. We sent them out into their communities to do education sessions. We evaluated the program and really demonstrated that this kind of on the ground relationship-based peer education can be really effective in endometrial cancer. I will just end by saying I had to push myself beyond this everything I just showed you before was really my comfort zone, but I had to remind myself that I'm interested in equity. I'm not interested in narrowing the gap. I want to eliminate the gap. And so it means that we have to contend with this issue of these biological differences by race, whereas why are Black women getting this high risk endometrial cancer? Why have they always gotten this more high risk type? Why on clinical trials are Black women still having lower survival rates, even when they're on a trial with very, very stringent criteria of treatment? And that really comes to this eco-social theory of disease distribution. And I will say I took 2 swings at this idea. So one swing was looking at structural racism and embodiment in endometrial cancer as an R01 back in early 2020. It was not funded. And then another one was an intervention-minded study saying, well, is it possible that we could use a community or social support intervention to actually influence treatment outcomes? And that is what became the sister study, and that was funded by PCORI. And so I will skip this for time. The sister study is based on this conceptual framework of using an upstream community-based intervention to influence treatment completion, which is a major variable in recurrence and survival, and Black women are much less likely to complete treatment. So the sister study is a national 10-site randomized trial. We're all over the country. We enroll folks, we randomize them to 3 different kinds of social support. We collect a whole boatload of information on them, including specifics about their treatment courses. These are our sites around the country. And our outcome is relative dose, which is how much of their treatment they actually complete versus what was recommended, and then their social isolation. We have a lot of gorgeous flyers that were all developed by our community. We have a recruitment video that we actually designed to specifically address each reported hesitation in the literature about clinical trial enrollment among Black communities, point by point by point. And had some of our survivors in the video. And I think that's why we're doing so well. So this is actually old. We've enrolled, I think, 126 people now. But we have 86% of our eligible participants across these sites choose to enroll. We have an over 90% survey completion rate at 6 months. And these are people who are on active treatment, getting chemo and doing all of this stuff. They stick with the study. And we've had no study withdrawals to date. So we're going to continue all of this work. Our work on early stage diagnosis, working on the guideline revisions, working on this public facing toolkit, and the provider intervention is TBD until I clone myself or find a very eager junior faculty member who wants to go ahead and kick that off. But it's just a bandwidth issue at this point. Ecana is now its own independent nonprofit. They continue to do community gatherings. They do research consultations with other teams and a lot of public awareness work. And then we continue to work on embodiment and outcomes through the sister study and a new, another R01 that I submitted in order to build a biorepository. And our goal is really to close the gap. This is the end, I promise. So we have a few other studies looking at ways to build this biobank in a way that's respectful to the community. We had another Purpori grant to evaluate social change roles in engagement science. I can talk more about that for anybody who has a question. And then this is our another swing at the R01 idea, which is looking at a concept called racial hypervigilance and biological outcomes on the sister study. And then these are some projects from trainees in our group who are doing really, really awesome things in a similar space that we're mentoring and excited to see what's going to come out of their work. Those are my amazing research team members at the Grace Center and the Department of OBGYN. And that's it. Thank you.
I think we can open it up. We have, a couple minutes before 1:30. If anybody in the audience has a question. Thank you, Kenny. That was amazing.
Thank you.
Fire hose. Yes, Karen.
So thank you. This was really interesting and impactful work. So thanks for your presentation. I'm curious, and I'm thinking about it from the lens of breast cancer. So I was thinking about, seeing that I think it was at 30 to 50% of type 2 cancers are type 2 in Black women compared to like 10% in white women. So thinking about that, are there social determinants of health or other socially patterned factors that increase that risk? And then when you showed that the type 2 was increasing, is it increasing disproportionately in Black women, or are white women also having increased numbers of or proportion of type 2?
Correct. So it is increasing disproportionately in Black women, but it is increasing in everybody. So that's one thing. Again, a central mystery is why that is. I think that it is definitely something social and or environmental exposure driven. Like, I think we're starting to think outside the box, thinking about like experiences with DES and things like that, with like in utero exposure to things that we just find out decades and decades later. With regard to why these types are different, we don't have good etiology studies in endometrial cancer on these non-hormonally driven types, because frankly, they have not been the priority until they're now affecting white women and everybody else. So now everybody is like, okay, what's really going on here? I think some of the it's been a long week. Molecular biology and tumor microenvironment work does point to somatic mutations acquired over the lifetime, like over adulthood, as opposed to inherited genetic susceptibility. It's not that there is no component of that, but that seems to be more of the driver of the TP53 mutation, for example. There's one study that just came out in Cancer, which I thought was so interesting, and it was comparing these type 2, for, to be very crude about the categorization. So it compared the type 2 versus type 1 among US white women, US Black women, and then the population in the French Caribbean. So I apologize because I can't think of the two countries right now, but the idea was that if the differential rate among US Black women is driven by this ancestral connection back from the transatlantic slave trade, then we would see the same patterns in Caribbean nations that you would see here in the United States among those Black folks, because this is like all pathways along the Atlantic slave trade. And they didn't. So the type 2 rate in those French Caribbean countries was a lot lower than the US Black women. So I can't answer your question, but I can give you some more fodder for thinking about it. We're behind, so we need a lot more biorepositories. a lot more ancestral studies, and a lot more work looking at the tumor microenvironment. It's a great time to get into endometrial cancer research. I mean, it's like very wide open for anybody who's interested. Right here.
Yeah, thank you so much for this talk. After this, I too hope that you can either clone yourself or
Oh my
find
gosh.
someone to help. I'm thinking about the second model that you showed with the,
Yeah.
I don't know, the lines coming off of the circle. And as a non-medical person, I'm imagining all of these questions that I want doctors to ask when people are, going to see their doctor. But given that, I guess I feel I have less control over that, I'm curious, what do you think about if there were a series of questions at each one of those junctures that people could bring to ask their doctor? What would that look like? What would that look like as a kind of intervention too, that put the emphasis, I mean, not to take a structural problem and turn it into an individual problem.
I understand what you mean totally.
Yeah.
So one of the first things we did on the Econo website, y'all should check it out, it's really nice, is that we created these know before you go guides. And one of them was know before you go abnormal bleeding, right?
Yeah.
And so it was literally a PDF that people could download, and it has all these questions. It's like, when did your bleeding start? So to prep them so that they're saying the kinds of words and like using the risk factor language that their doctor would be like, wait a minute, we should get something. So honestly, outside of the research and just thinking more about community action and grassroots action and intervention, we started doing that in 2017. In terms of the toolkit, which I talked about very, very quickly as running out of time, that is involved in that. So the toolkit is both education and awareness. So this is what endometrial cancer is, et cetera, but also how to assess your own risk. And if you're having bleeding right now, how would you make your decision about, do I need to go to the doctor? What should I do? Do I need an ultrasound? Maybe an ultrasound isn't great for me. So it's really designed to be an interactive, almost like decision support tool before you even get to the doctor. So there's that. On the provider side, I think there are a lot of things that we have just decided to pull out and say, this is probably important, we should ask for people. I can't go to the doctor without them asking if I do a self-breast exam. I mean, that's like part of the annual visit, is like, you doing that, right? I mean, it's always a question. We have room to add something like, just so you know, if you ever have spotting or bleeding again, you should definitely tell me. I mean, most of the women that I don't practice anymore, but when I was clinical, and I mean, it was so often they would say, I've never even heard of this cancer. Like, talk less of being surprised I have cancer. I didn't know this thing existed. And I was sitting there thinking, this is the most common gynecologic cancer in the United States. This is my bread and butter. Why would women have no idea that it exists? It's 4 times more common than cervix cancer. They are vastly more likely to get this than cervix cancer on any given day of the week, twice on Sunday, but they've never heard the word. They've never even heard of it. So I do, yes, individual empowerment, and we need public health messaging, and we need an upgrade in our provider education and ongoing awareness of it.
That was great. I think we should let you chat if you have time
Sure.
afterwards. Thank you so much.
Thanks, everybody. One Q&A.
Oh, shoot, just with Teresa Ward.